Hi, my name is Monica Bailey, and this is my business plan proposal for a hospice in Las Animas County, Colorado. So why a hospice business plan? Currently, 72% of the hospices in America are for-profit businesses. CMS, or Centers for Medicare and Medicaid Services, only requires very bare bones, meaning RN visits, CNA visits, chaplain, and social work to qualify as adequate hospice services. So what we see in the hospice and palliative care field is a lot of older people using their benefit because a lot of America is aging, but they're really not getting the services they deserve. A good example of a counter to that is Pikes Peak Hospice and Palliative Care in Colorado Springs, Colorado, because they are nonprofit and they offer a lot of ancillary services such as volunteer services, music therapy, pet therapy, and a very extensive bereavement program, an extensive palliative care program, which is not something that CMS covers. So they're a good example of what can be done if you do hospice the right way, and that's what compelled me to write a business plan about hospice. Now, this relates to the advanced practice registered nurse role because APRNs have the responsibility to advocate for quality healthcare and healthcare access, and that includes end-of-life care. A lot of people do not receive hospice within a timely manner when they're eligible. A lot of people are only on hospice for a few weeks before they die. And while that's helpful, it's not quite its function. It's supposed to augment your quality of life once you have a terminal illness of 6 months or less. Palliative care is meant to do the same thing if you have an illness, but you're not terminal within 6 months. The following business plan will show the potential APRN impact on hospice patients if an APRN is to actually run one of these businesses. So how is this relevant to APRN practice? Well, APRNs have been fighting for prescriptive autonomy across the country for decades. And having an APRN owned and ran hospice would be advantageous in showing that nurse practitioners and other APRNs are qualified to serve in these independent provider roles. Currently in Colorado, I would have to have at least a part-time medical director because nurse practitioners and other APRNs are not currently allowed to pronounce death, sign death certificates, and certify terminal illness in the state of Colorado. So to further my point, having myself as a nurse practitioner running a hospice could show why maybe those laws should be overturned. So why Las Animas County, Colorado? So in recent years, only 35.2% of CMS decedents in very rural areas, such as Las Animas County, took advantage of their end-of-life benefits, as opposed to about 50% in urban areas across the country. So there's a clear underutilization due to multiple factors. Las Animas County has about 14,000 people. Of that, 30% are 62 years or older, as opposed to the 18% in the rest of the state. 40.8% are Hispanic, 4.7% are Native American, 10% are military veterans, 10.3% speak Spanish as a primary language, 39.8% of those that are 65 years and older live with one or more disabilities, and 11.8% live below the poverty line. So we have a very vulnerable population that is underutilizing hospice. So not only is there the opportunity to help these people, but there's an opportunity to significantly grow an end-of-life business. Other stakeholders that should have interest in more hospices in Las Animas County would be the local critical access hospital in Trinidad, the local Veterans Affairs Services, because of the large amount of military veterans that live in this county that could benefit from a partnership with a hospice, and local nursing homes, including assisted living, independent living, skilled nursing, who could benefit from having the extra services that hospice provides in tandem with those nursing homes. So I truly believe in the nonprofit hospice business model. I feel like it brings the most benefits to the community it serves. So I would be starting a nonprofit hospice in Trinidad, Colorado, with the goal of serving all of Las Animas County and the neighboring eastern regions of Herfano and Costilla. This would, of course, be contingent on what the state approves, because anytime you start a new hospice in Colorado, you have to petition to the state for service area. I would strive to provide culturally and linguistically appropriate services or class, because this is a vulnerable population that is very diverse, and those cultural barriers can easily become impedance to care, or they can enhance care depending on how you approach it. So like any healthcare business, it's a balancing act between how many employees you hire, how fast. So I would start with a very small initial management and initial team. The initial management team would include myself as a nurse practitioner who would do the majority of prescribing, a part-time or full-time medical director, because as I stated, in the state of Colorado, you need that to be able to run a hospice. There are certain things that APRN still cannot do. I would also have a director of nursing. This director of nursing would not only be management, but would also serve in all registered nurse roles until the census grew enough to differentiate that. I would also hire a human resources expert that would do IT work and the very obvious human resource needs. My initial team would include that DON covering the RN role, one CNA, one social worker, and one chaplain that cross-covered bereavement services, because that is truly what's required by CMS. And our initial ratios would be RNs 12 to 14 to 1, CNA would be 13 to 15 to 1, contingent more on visits. Social work would be 50 to 1, and chaplain would also be 50 to 1. Once the team starts to grow and expand, which I will go into more in detail later, we would start to branch out into palliative care services, liaisons, which are basically sales, but they're partnerships in the community. So we have different types of liaisons, clinical liaisons especially, that will go out and partner with different skilled nursing facilities, and veteran liaisons, which partner with the VA. And they would also preferably have class training. We would branch out into a volunteer program, and we could offer services like music therapy, pet therapy, an extensive volunteer program, massage therapy, and then eventually the management team could be differentiated out into the president and clinical management under the DON. So there's about 4,200 people that are age 62 years or older in Las Animas County. Now, it would be naive of me to think that all of those people would even be remotely qualifying for hospice or palliative care services, but that is a larger pool to grab from than the average in Colorado. The next part of planning my market analysis would be a SWOT analysis, which includes looking at strengths, opportunities, weaknesses, and threats. And this is an analysis to look at how viable a business can be in a certain market. So strengths and weaknesses look at internal factors within your company. The strengths of my proposed business plan would be that Las Animas is very rural. So as I mentioned, there is an underutilization of hospice services in this area. A larger portion of the population is older, so they are more likely to need hospice services. There's a large population with disabilities, so even further. There's a large population that lives below the poverty line that could take advantage of Medicaid services for hospice. We could be providing culturally competent care, hiring staff that speak Spanish, and that would set us apart. We could have the nonprofit business model, which would offer extensive services, as I mentioned, including veteran liaisons, music therapy, pet therapy, etc. We would also look into eventually having an inpatient unit for patients that needed respite or inpatient care to manage uncontrolled end-of-life symptoms. And we would serve all of Las Animas County. Currently, there is 2 hospices in Las Animas County. They don't serve the whole county. Lots of the very eastern portion of the county are covered by neighboring counties' hospices. But I argue that access to care would be better with an in-county hospice that guaranteed to cover all CMS recipients in the county limits. Now we look at internal weaknesses. I would need initial funding. So the goal is to eventually have a philanthropy foundation attached, possibly a separate nonprofit organization that's goal was to fund extra nonprofit services from the hospice. But that will come probably over the first 10 years. So I would probably need about $500,000 in initial loans. That's no easy feat. The lack of a current affiliation with a larger organization for upper management ancillary services will limit how much I can do in the community until I can obtain that affiliation. The lack of space and funding for an inpatient unit. Having an inpatient unit really sets a hospice apart. But for example, right now in Colorado Springs, Pikes Peak Hospice and Palliative Care is spending over $8 million to build an inpatient unit. So it's not something that a hospice that is new can do. And then we have a lack of current partnership with local hospitals and facilities. So we don't have a partnership with any of the VAs, any of the local nursing homes, the critical access hospital. And those are partnerships that really further, through word of mouth, business. So opportunities and threats look at external factors. Opportunities would be the fact that there's only 2 hospices currently located in Las Animas County. Like I said, there's others that serve parts of the county, but that's it. And those 2 hospices do not serve the whole county. There's a small critical access hospital in Trinidad. They have limited space. Hospice and palliative care has shown to decrease unnecessarily hospitalizations and emergency department visits. So a local critical access hospital with limited space is going to benefit from lack of unnecessary visits into their ER. The threats are kind of the flip side of this. So the 2 other hospices that do exist in Las Animas County are also in Trinidad, and they're both nonprofits. So they have the same ideas about expanded services, and they go out of their way to serve veterans. So a lot of our same goals are shared with them, which makes them competition. And there's an increasing rental and or owning cost of property in Las Animas County as there is across the country. So while a small social media presence could be helpful, the bigger idea behind the sales plan is going to be campaigning right to the source. So in my work as a hospice nurse, I've noticed a large disconnect in education on end-of-life services, even in geriatric providers. So going to conferences like the Colorado Medical Directors Association conference, which is annual, and providing education on hospice and palliative care services and when their patients are eligible for those would be beneficial because you're more likely to see more referrals out of the community that way. Also, marketing materials like pens, pads that are branded with the logo and the name would be beneficial because those are things you can hand out at conferences, and then the next time someone's looking for a referral, they're more likely to see that and call you. So the way hospice is reimbursed is primarily through CMS. So it's very important to maintain compliance with CMS regulations and to analyze what potentially could be coming in fund-wise. So first of all, hospices that are new are usually ran pro bono for about 2 months because they need accreditation by the state or another agency to receive reimbursement from Medicare and Medicaid services. So routine home care is what most hospice patients are on. It includes the care team going out to the home anywhere from 2 times a week to 1 or 2 times a month. So that is about $250 a day per patient for the first 60 days. Then it drops down to about $200 because CMS wants you to keep proving that that person is still terminally ill. Many patients will pass before the 60-day mark. General inpatient care, as you can see, charges or reimburses over $1,300, and that's because this is reserved for patients that have severely unmanaged symptoms that cannot be managed in a routine home care environment. So you really have to prove to CMS that they needed that because the reimbursement is so much higher. Respite is basically routine home care but done in an alternate setting, such as a nursing home or a hospice inpatient unit, so that the caregiver can have a break. So that's why that is reimbursed a little higher per day. And then there's some add-ons. So continuous care would be if a patient's symptoms are unmanaged, but for some reason they can't go to general inpatient, or they don't want to move from the house, or it's a intermittent crisis that can be fixed. You need to have a nurse in the home at least 8 hours per day to receive this add-on to the routine home hospice. And then there's the same $76 add-on for last 7 days of life, and that's if somebody is believed to be on what we call end-of-life protocol. Any day within the last 7 days before their passing that a social worker or nurse sees them, you get this extra $76. Now, these are the rates in Colorado's very rural counties. The urban counties tend to have lower reimbursement rates, but Las Animas County, being very rural, falls into this category. So when interviewing my current clinical manager at Pikes Peak Hospice and Palliative Care, who has served as a DON and started her own hospice in the past, she recommended about $500,000 in initial loan, and that's mostly to cover about the first 6 months of services. And remember, the projected income for the first 6 months is going to be very low because of the pro bono work until we're accredited. So I'm estimating about $465,000 in revenue for the first 6 months. And then if I reach a census goal of 40 by a year, it would be about $1.85 million for the year total. Now that needs to be broken down into a percent of net revenue with a 4% operating margin, which is usually what is recommended in nonprofit. For-profit businesses have a larger operating margin, but nonprofit, the point is to show that you are tax exempt because you're providing a service to the community, so you cannot have a large profit margin. You need just enough to be able to reinvest in your staff and your business, and therefore the community. So labor would be no more than 68%. This includes both salaries for employees and their benefits. So even if it cost $150, let's say, to employ a medical director, about 30% more is going to be needed to actually employ them for their benefit package. After adding up all of my staff that I would need for the first year, the cost to employ them would be about $855,000. Direct patient costs, which include contracted pharmacy, medical supply company, transportation, employee mileage reimbursement, and basic stocked medical supplies, are not to exceed $203,000 in the first year, as this is 11%. Facility costs, this is one of the smallest buckets. This should not exceed 1.8% or $33,000 in the first year. Looking at the cost of renting an office space in Las Animas County could be anywhere from $24,000 to $48,000 for the first year. So the goal would be that I find an office space for around $24,000, because I'm also going to have to find room in that pot for liability insurance, telephone, and internet service. Other operating costs, which include marketing, employee appreciation, meetings, recruitment, printing, any legal fees like a malpractice lawyer, especially for providers that are employed, would be 7.6%, which is not to exceed $140,000 for the first year. I set aside about 2% of the net revenue for depreciation and loan, and 5.6% for affiliate costs. Now, probably won't make affiliate for the first 10 years. So that money can either be divvied into other categories in some way, as it would need to be to keep the operating margin correct. But I did allocate that separately so that when the time comes, I do have that funding already planned for. My census goals would include 40 patients by the first year, average of 65 patients by the second year, and an average daily census of 80 patients by the third year. These are based off of realistic expectations from someone that has started their own hospice. I would hire a second RN at about 18 patients, and then I would hire another RN every 10 patients that were added to the average daily census. I would hire a second CNA at about 15 patients, and then every 15 patients. I would hire a second social worker every 40 patients, and a chaplain about every 70 patients. Clinical managers would obviously just include the DON at the start, but I would hire my first clinical manager at about 50 to 60 on the average daily census, and then management would further differentiate from there as the census grew. Liaisons and other ancillary staff will only be added after that $500,000 initial loan is paid off and the census is stable and it's financially viable. Other people that would be in that ancillary staff category would be a dedicated bereavement team, palliative care services, volunteer coordinators, foundation president to run the nonprofit foundation that will have a philanthropic fund to go into our services. Other goals with growth would include the inpatient unit, the affiliation, and palliative care services, with a goal of obtaining these within the first 10 years while also growing that foundation. The theoretical framework I would use for my hospice agency would be this 6S model for palliative care. This is a holistic approach to palliative care. It acknowledges universal basic needs among humans while also acknowledging that those needs, including physical, psychological, spiritual, and social well-being, are different for every single patient. And the goal would be to personalize their care so that we can achieve the best quality of life for them at end of life. These include the 6 S's, which are self-image. That's preserving self-image. So if you think about it, we all have a way of looking at ourselves in our head, and that way can definitely be distorted during the dying process. But if you maintain dignity and respect somebody's wishes, you can help preserve that self-image of them. Self-determination is really psychological needs. Synthesis and strategies is addressing spiritual and existential needs, especially making sure that a patient can die in the manner that they wish to. So whether that be in the hospital, it's really not for most people, in a home environment surrounded by family. We look at social connections, that's obvious, that's social well-being, and symptom management, which is a huge part of hospice and palliative care because that's the whole goal. We're no longer in the paradigm of curing illness. We are in the paradigm of palliating the symptoms of illnesses that can no longer be cured and are causing the patient to be terminal. Success at a hospice agency, in my opinion, is measured through quality. Yes, you can look at census numbers, but there's many other surveys and audits you can do that will show whether you're actually beneficial to the community. So conducting routine audits would include making sure that your nurses, your aides, your care team is not only providing the services, but charting to the services correctly. So are patients admitted for the right terminal illness? Do they qualify for that terminal illness? Do they qualify for the level of care they're at? Are they still hospice eligible? Charting is a very important piece of maintaining a financially viable hospice, because if you didn't chart it, it didn't happen, and CMS will see that as Medicare fraud. And then you will have to repay large amounts of money, usually years on the back end. Another good way to look at quality assurance and measure success is the CAP survey. This is the Consumer Assessment of Healthcare Providers and Systems survey. It is given to all caregivers 2 months post-mortem, and it looks at how did we communicate, how did we manage symptoms, did we give you timely help, did you feel supported, how willing are you to recommend this hospice. And how it works is that if you don't mark the highest recommendation, the score does not count. And this goes to CMS, and CMS puts out a public website with star ratings from 1 to 5 for hospices. You can only get these star ratings once you have a 50 patient or more census maintained, but it is a really good way for consumers to evaluate whether they should pick your hospice or another hospice. Some extra considerations include the electronic health record that would need to be used. Currently, NetSmart is a functioning electronic health record. There is, in my opinion, no current perfect electronic health record for hospice and palliative care the way that there is in inpatient care. So I am partial to Epic. I feel that Epic is very evidence-based and constantly building on itself, and I know that it's very expensive. And there is currently no hospice and palliative care extension, but I would love to see a hospice and palliative care extension of Epic in the future. Not only would that help with interoperability, but I think that it would benefit patients and be easier for staff. They could spend more time on care, less time on charting because of the workability of the system. Also, I would be remiss if I didn't mention Medicaid. So social workers can help people apply for Medicaid and provide education to the community. This would be especially important for patients in Las Animas County because not only can Medicaid cover your hospice benefit, but Medicaid can cover room and board at a facility. So for many aging elderly people who can no longer live alone but cannot afford the obscene bills associated with long-term care residents, this is a huge opportunity not only for the hospice, but for the benefit of our elderly in the community. In summary, this is why I have chosen to select a nonprofit, NP-led hospice, eventually hospice and palliative care, in Las Animas County, Colorado. We would provide culturally and linguistically appropriate services and routinely check for quality assurance. We would use the 6S palliative care model, as I recently mentioned, and I would have that initial loan of $500,000 and the team and growth plan, as I mentioned. And I believe that this would be not only successful, but would benefit a large vulnerable population in Colorado. And that's why I chose this business plan. Attached on the next slide are my references. Thank you for listening.